Okay, so Assalamu alaikum and good afternoon, everyone. I would like to thank the organizing committee for the invitation, and I want to thank Dr. Mazen for the very nice introduction. So today I'm gonna talk about how can we improve upfront therapy in newly diagnosed myeloma. So, as everyone knows, that myeloma is an incurable disease, and the patients, even after any therapy, they will come to a time that they will relapse. And you know, I think everyone who deal with myeloma patients would know that the longest remission is the first remission. So now, you know, the focus is how to optimize this upfront therapy, because, you know, the condition of the patient will be at the best at that time, and usually that remission would be the longest before the patient had selected a resistant clone. And also, one of the challenges with the myeloma patients that as the time goes, we lose some patients. So some they become refractory, and and they get more sick, which would be difficult to treat that group of patients. And as we can see here, once the patient becomes to a status of triple or quadruple resistance, their median survival is very, very short. So that's why we try to hit hard at the beginning, because that will, at that time, the PFS would be the longest. But we have to keep in consideration that our therapy is not free of complications. So there are some risks. So we have to balance between the benefits and the risks. So how aggressive we have to be. So this data from the IFM 2009 trial, and we can see here that patients who achieved MRD negativity, they did the best, regardless their risk status on presentation. So I think in 2022, we have to be more ambitious and go beyond CR or stringent CR, aiming for MRD negativity. So this is the roadmap of any newly diagnosed myeloma who is transplant eligible. So we would start with induction, first transplant, second transplant, consolidation, and then maintenance. So how can we improve induction in patients who is newly diagnosed multiple myeloma who is transplant eligible? So any induction, to call it successful, it has to be fast working, give you a deep response, well tolerated, available, and does not interfere with the stem cell collection. So we all know about the IFM 2000 trial using VRD, and based on that trial and based on the very acceptable and excellent results, VRD became the standard of care in many centers as an induction for transplant eligible patients. But how can we do better than that? So there are multiple ways that we can think of that can improve the induction in newly diagnosed myeloma patients. So addition of monoclonal antibodies, so a quadruple regimen than triple, using a different proteasome inhibitor, combination of all of that, and using other novel agents. So the Griffin trial actually looked into that, and they add daratumumab to a backbone of VRD, and that was tested in transplant eligible, and the patient would go for transplant after 4 cycles of dara VRD. So this trial has showed improvement in the results and the post. Where's the pointer? Okay, so yeah, so we can see here in the post induction. So the patient achieved better responses in comparison to the RD. So more CR, better VGPR or better. And also in terms of the MRD negativity post-induction, we can see here that patient post-dara VRD had deeper responses in terms of MRD negativity. But, you know, although it was not clearly pronounced, you know, that was associated with increased use of plerixafor during the stem cell collection, so that's something you have to keep in your mind. And that actually resulted in a better PFS It's still the mean PFS not reached after 3 years of follow-up, but we can see here that the curves are split and with a significant hazard ratio. On the other side, in France, in the IFM group, they tested the Casubia using their standard induction, which is VGD, with addition of daratumumab. And also they did another idea, which is randomizing the patient to receive either maintenance dara versus observation. And as we can see here, the same results. So addition of daratumumab resulted in deeper responses in term of CR and also MRD negativity, which tell us that addition of daratumumab has improved the outcomes of induction in these patients. With achievement of MRD negativity, we can see here that patients who achieved MRD negativity, they did better. Isatuximab also has been tested in that group of patients, so that was presented in the last ASH. So the addition of isatuximab to RVD versus RVD only, and still the results are not quite mature, but we can see here the MRD negativity was achieved in about 50% more than the VRD only arm. Also, another PI could be used. So in this trial, the endurance, they looked at use of VRD versus KRD in patients who are transplant eligible. And actually, what the interesting thing about this trial that the substitution of carfilzomib versus bortezomib did not result in improvement of the outcomes, but there was a higher risk of some toxicities, mainly cardiac and hypertension. So how about we combine all of this? So the master trial also looked into that. So the DARA KRD versus KRD, and they used MRD adapted approach, which is something really, I think I would see it interesting. So patients would receive 4 cycles of KRD followed by transplant, and based on their MRD response, they can come off therapy, which means that the maintenance therapy or the consolidation will be limited for that group of patients. So they included actually patients who are high risk based on their high risk cytogenetics, and also based on ISS stage. So that's actually difficult to treat patients. So this is a very intense regimen, and then we can see here there was increased risk of adverse events, and also there was some mortality associated with this regimen because of mainly because of pneumonias and because of infections. So that's something you have to keep in your mind as well. But as we can see here, this regimen associated with the deeper responses. So VGPR or better was achieved in 88% of the patients post 4 cycles of inductions. And what's interesting about this trial is what happened with the patients with the high-risk cytogenetics. So we can see here the 2 high-risk cytogenetic features, which is the double-hit myeloma. And I think all of you agree that these are the most difficult patients to treat. And we can see here with the DARA KRD, there was no significant difference between the patients who had low-risk cytogenetics versus the high-risk cytogenetics. So that's such an intense induction might overcome high-risk cytogenetics. And as we can see here, with the use of DARA KRD, the PFS was still acceptable. So 2 years of overall survival is 76%, which is, I think, for that group of patients is still something good achieved. So what about transplant? After all of the data that I showed you, do we still need a transplant or not? So that question was answered in the IFM 2009, and despite using a good induction like VRD, transplant was still of an advantage and associated with increased or higher PFS. But on the other side, the cardamom trial, which was presented last year in ASCO, they used a different induction, so KCD 4 cycles, and then the patient will be randomized to go for transplant or to receive 4 more KCD cycles, and then everyone will go on carfilzomib maintenance. And we can see here there was no much of difference in terms of PFS between the two groups. So which might, although that's different than what we learned from the Endurance trial, but this trial showed the use of carfilzomib in the upfront setting might, overcome the need for stem cell transplant. Also, this trial, which was run in the MSK Center 2 years ago and presented in ASH. So basically, they looked at giving the patient 8 cycles of dara KRD, and we can see here the results were quite impressive. So overall response rate was 100%, with a VGPR or better up to 97%, with MRD negativity of 75%. And we are talking about only chemotherapy with no transplant in that group of patients. So if we decided that still there is a space for transplant, which I think this is the practice in many centers, so what's the optimum conditioning? So melphalan still is the standard of care in many centers and after the IFM trial. But all of these conditioning has been tried, and I'm going to mention few trials done on this. So the busulfan melphalan has been tested in this paper, comparing it to the melphalan only, and we can see here associated with the addition of busulfan associated with a better PFS but no survival benefit, and there was no significant signal of risk associated with the use of both busulfan and melphalan. But the thing is, I think the level of comfort what might be of an issue, because here you have to calculate the amount of busulfan you have to go to every individual patient based on the area under the curve. Also, bendamustine and melphalan has been tried in this single-arm trial, and it showed that the PFS was 4 to 8 months, which is something quite good, with no also major safety concerns. Also, bortezomib and melphalan was tried in the IFM group, and we can see here also the results were good. They compare it to their historical database from the IFM 2005. And as you can see here, the response rates were better with the use of bortezomib and melphalan. But as you can see here, the number of patients were tested were small, so it's difficult to come with a conclusion out of this. Consolidation, do we still need to give it or not? So the EMN H095 trial presented by Dr. Kavu a number of years, it showed actually improvement with the addition of consolidation. But keep in your mind that the induction was given here is not the optimum, it's not the one that we use now. On the other side, the Stamina trial with the use of VRD as an induction, it did not show that improvement. So that's why in most of the US centers, consolidation is not quite a standard, but you go to Europe, you will see that consolidation is still of a use. So there is a debate about this point, as you can see. What about the maintenance? How can we improve it? So I think all of you are familiar with these 3 important trials looking at the efficacy of adding maintenance in patients with a newly diagnosed myeloma. And as you can see here, all of them associated with improvement in the PFS. One trial associated with improvement in the overall survival as well. But can we do any better than that? So the addition of daratumumab to a maintenance therapy of lenalidomide in the Griffin trial associated with also better outcomes, and which means that maintenance is not just to maintain, it's actually to deepen the response. And that's what we see now. After 2 years of maintenance, the amount of the patients who achieved deep remission in form of CR were better in comparison to len maintenance. And the same thing was also from the Cassiopeia, so the addition of daratumumab to, as a maintenance, also associated with a sustained MRD negativity rather than observation. But one of the interesting findings in the Cassiopeia trial that daratumumab maintenance improved the response in patients who did not receive it in the induction. So for someone who received daratumumab as part of their induction, addition of daratumumab to the maintenance did not improve their outcomes much. So what's next? So I think, we have to think out of the box, and one size does not fit everyone. And as we are doing with many other cancers, MRD adapted approach would be, I think, the preferred way. So in the MASTER-2 trial, so still it's enrolling, they are looking at this concept. So we are adapting or changing the patient's regimen based on their MRD achievement.
Dr. Majed, you have 5 minutes more.
Yeah, so about 2 minutes I will finish. So what about the newly diagnosed transplant ineligible? So I think you're all familiar with the ELSEON trial looking at the addition of daratumumab to VMP, which associated with a significant improvement in the patient PFS measured at 42 months, so 48 versus 14 months, and which something we don't see commonly, an overall survival benefit, as we can see here at 42 months. So it's clearly daratumumab addition to the transplant ineligible patient did something. But actually, most of the advantage was clearly shown in the Maya trial, testing dara RD versus RD. Okay. And this actually, the result of this trial was presented just a few months ago and is still showing the significant results. So we, at 56 months, so we're talking about more than 4 years, in the DARA RD arm, the median PFS was not achieved yet. Okay, and you can see even in the survival curve, the curves has started to split. And we can see here also how deep a response we achieved with the DARA RD, so 31% versus 10%. So as a conclusion, we can think that novel agent combination has resulted in significant improvement in the outcomes of newly diagnosed myeloma. Combination of novel agents plus monoclonal antibodies in the upfront setting might be a new standard of care, okay, especially in the transplant ineligible patients. Longer term follow-up required to assess the clinical impact of this combination. Response-adapted therapy might be the future in the multiple myeloma therapy to avoid unnecessary exposure. That's what I have for you, and thanks for your listening.